Hello, my name is G.Gazzard. I'm Professor of Ophthalmology at UCL and Director of the Glaucoma Service at Moorfields Eye Hospital. I've had an interest in angle closure glaucoma since my time in Singapore, 20 years ago now, and where we ran a randomized controlled trial of 5FU in trabeculectomy surgery, but also set up some randomized controlled trials of angle closure treatment. I have some funding acknowledgements, potential conflict of interest, but none of these seem to apply to angle closure and for the subject of this discussion. I was asked to talk about angle closure conundrums, and I thought I would talk about some specific treatment questions. Some of these things have changed recently, therefore they're of particular interest. Talking about who needs a laser iridotomy and perhaps a little bit on where that might be placed, who needs a clear lens extraction, who may need drainage surgery, and what are the exceptions in special cases. This is a huge area of research, treatment debates, differences of opinion, and variations in clinical practice. So what I'd like to describe is some of the evidence, some of my clinical practice, and on occasion, some of my opinion. This is not necessarily to say that other clinicians whom you may work with will not have different opinions, and they may well indeed be right. And the English would say there's many ways to skin a cat. There are many ways to arrive at the same correct point. But what I'd like to do is to talk about some of the principles and to really refresh our minds about some of the recent research which has been conducted and the way in which we may apply that to our practice. Ultimately, all of our questions in medicine are a balance between risk and benefit. Whether that's taking a paracetamol for a headache, giving a small child antibiotics for a painful ear, making a decision to do radiotherapy or surgery for cancer. We're all weighing up risks and benefits of often quite complex medical decisions. And sometimes we work by algorithm and it's straightforward because we know that the risks are clearly outweighed by the benefits of that particular intervention. So giving antibiotics for a severe chest infection or for somebody who is septic, it's really pretty straightforward. Giving antibiotics for somebody who's only very mildly affected, however, may or may not be of benefit. So we therefore weigh up these risks, sometimes unconsciously because we work to algorithm, and sometimes much more consciously because the individual patient in front of us is more complex or more difficult to assess. And when we do that, we need to ask ourselves, where is the evidence for what we're about to do? And there was a lot of talk 10 years ago about evidence-based medicine, which has its limitations as an approach because we're slightly in danger of a one approach fits all, algorithmic, unnuanced discussion for an individual patient. And we need to get away from that and remember that each individual is a very specific individual with their own concerns and cares, as well as their own complex set of risk factors for each particular decision. But also we need to get away from the idea of eminence-based medicine, that we would do treatment A simply because the boss says so, or that's what the grey-haired old professor around the corner tells us to do. We need to think for ourselves, reach for the evidence, sift that evidence, weigh it up, and then apply it to the individual patient, present it to them in a way that they understand, which will be different for a rocket scientist and a plumber. Give them an analogy that they can understand, help them to make the decision, and make sure that they understand why you've made the decision that you have, or recommendation that you have. We've got a lot of different sources of evidence that we can reach for. The angle closure and angle closure glaucoma guidelines in the consensus series, which do need updating. The European Glaucoma Society terminology and guidelines for glaucoma, which are being reprinted and republished as we speak. But also Cochrane reviews, the Cochrane Library of Medicine, and other sources of meta-analyses of data are very important sources of overviews of the research and evidence that we need to draw on. What is it that we are treating? Well, I'm referring to primary angle closure disease in its greater, sort of most broadest sense, which means eyes in which there are primary iridotrabecular contact. That is, iridotrabecular contact in the absence of other causes. So not eyes where there is secondary iris bombay due to chronic inflammation causing uveitis with synechia to the lens. Not eyes in which there's chronic inflammation causing primary peripheral anterior synechia because of the inflammation within the front of the eye. Not eyes in which there are congenital developmental defects causing adhesions between iris and meshwork. But eyes in which there is no other apparent cause other than a degree of iris bombay because of a mixture of pupil block and non-pupil block mechanisms, such as plateau iris or thick last iris roll or enlarged peripheral iris thickness, and any of the many terms that are used for the non-pupil block mechanisms of disease. Within this broad grouping of primary angle closure disease, we need to look at whether the pressure is raised or normal, the presence of peripheral anterior synechia, PAS, or not, and most importantly, the presence of glaucoma or not. Are the visual field and optic nerve normal or abnormal? If all of these things are normal, then iridotrabecular contact alone means that the patient is a primary angle closure suspect, has PACS. If there is pressure or PAS present in the eye, then that eye has PAC, primary angle closure. And if there is the presence of glaucomatous optic neuropathy, then that eye, with iridotrabecular contact and GON, has primary angle closure glaucoma. There's a fourth entity in the angle closure disease spectrum, which is acute angle closure or acute angle closure crisis, as it is sometimes called, which is a constellation of signs and symptoms of acute, sudden onset, very high pressure with pain and a red eye with congested iris. Now, in the past, we've used prophylactic laser peripheral iridotomy for PACS, and I want to talk about that later on today to decide whether or not we think that is still valid. We need to aiming to prevent visual loss from acute angle closure and primary angle closure glaucoma, and we're aiming to do that with the minimum intervention. So, who do we think needs a laser iridotomy? Well, traditionally it was anyone with closed angles. So until several years ago, we were recommending laser iridotomy for anyone with iridotrabecular contact beyond 6 o'clock hours. This has changed. The natural history of angle closure, progressing from angle closure suspects that we just defined as those with no pressure, no PAS, no glaucoma, but some iridotrabecular contact, through a series of stages of angle closure to angle closure glaucoma, has a very uncertain rate of progression. We know that some people go through these steps, but we don't know how many. And with more difficulty, we don't know how many develop acute angle closure. These are huge uncertainties and vary probably between different races, so data from some races may not apply to other races. We do know that an iridotomy will have a significant impact on anterior iris curvature. It will relieve pupil block. It will open up the drainage angle. And there are literally dozens of papers looking at imaging of the effects of laser peripheral iridotomy on this slide in ultrasound pictures from back in 2000 in Chinese eyes from one of my studies, or in this eye after PI, showing that with a flat iris plane, so the removal of bombay the pressure differential between the front and the back of the iris, or the anterior posterior chambers, has been relieved by an iridotomy, but there remains iridotrabecular contact. And this contact, importantly, is seen after iridotomy in up to, or sometimes over, depending on the study, a third of patients. So laser iridotomy does not remove iridotrabecular contact entirely in many patients, in many different studies, in all races. That applies in Caucasians as well as in the Chinese. And let us remind ourselves that one of the most important precepts of medicine, attributed to Thomas Sydenham back in the 17th century, is first, do no harm, primum non nocere. Sometimes it is best to do nothing. What sort of problems can we cause with a laser iridotomy? Well, we know that there are significant rates of iridotomy-induced dysphotopsia after laser PI. Some people attributed this to some people attributed this to the position of the iridotomy, whereas others would say that it was simply a matter of the additional iris hole and changing anatomy of the iris that generated this in some patients. A number of studies have attempted to quantify and look at whether the iridotomy should be temporal or superior on the basis of this significant rate of dysphotopsia, which in a very small number of patients causes very great problems. The Zhongshan angle closure prevention trial, the ZAP trial, showed that there was no significant difference depending on whether these iridotomies were totally covered or partially covered or totally uncovered. So there was no difference with hole size or location. Another prospective randomized controlled trial showed that around 10% of all patients, 9% of all patients had new onset symptoms with various forms of glare, blurring, or dysphotopsia, and that there was no difference with the positioning of the iridotomy. So a significant number of patients have new problems, but where you put the iridotomy did not seem to have a significant impact. So where you place the iridotomy does not seem to have an impact on the side effects, but significant rates of side effects there are. Which brings us to more detail about the ZAP trial, the Zhongshan Angle Closure Prevention Study, which screened almost 12,000 Chinese individuals to gather almost 900, in whom one eye was treated and one eye was observed, with an intention to treat analysis in the paired eye design, published in The Lancet in 2019. The endpoint was incredibly uncommon. The initial 3-year follow-up was extended to 6 years because at 3 years there was no difference. There was, in these almost 900 patients, a small difference in the rate of angle closure of 1 in the treated eyes and 5 in the untreated eyes, but many of these were iatrogenic rather than spontaneous, occurring on pupil dilatation for other reasons. There was a modest, significant, but very small treatment effect, which translated into the difference between around 4 and 8,000 eye years of endpoints being reached, where most of the endpoints reached were 1 clock hour or more of peripheral anterior synechiae. In these 900 eyes, the significant endpoints of raised pressure on more than 2 occasions or acute angle closure was seen in only 4 and 10 eyes, respectively, after 6 years. So to reach any form of endpoint of any sort needed 44 individuals to be treated for 6 years, where most of those endpoints were clinically insignificant peripheral anterior synechiae. The figures are clearly much, much higher if you consider pressure and angle closure, acute angle closure, to be the only significant ones. There is another similar study looking at outcomes following primary angle closure in Asian eyes. And what this shows is that in acute angle closure, eyes actually did extremely well after laser iridotomy, with 80% having good IOP control, 90% achieving 6/12 or better. And other series have found similar outcomes. In a European study back in the 90s, 3/4 were controlled without medications after laser iridotomy alone, and in Japan, 81% were controlled with no surgery. Even better rates with early lens extraction of 90 to 97% from a randomized controlled trial that we conducted in Singapore that I set up back in 2001, show that with early lens extraction, 90 to 97% of individuals presenting with acute angle closure had controlled pressure without treatment at 2 years follow-up. So clearly acute angle closure itself is not as blinding as we once feared. It occurs much less often in these patients than we once feared. And so the proposal for this is that we need to do fewer laser iridotomies than we once thought. Another study also looking at angle closure eyes, the ANA-LIS study that you may come across from Ong Tin's group, but that also involved Paul Foster and David Friedman, who were involved in the ZAP trial, looked at primary angle closure suspects who were recruited from clinic. Excuse me. And this study had a lower proportion, a lower number needed to treat of around 20 for reaching the endpoint. But bear in mind that these were patients that came to clinic. They had other concerns. They may have been more symptomatic. They may have been higher risk. There were other reasons for them to present. And once again, primary peripheral anterior synechiae were one of the major outcomes in these patients. And the proportion of patients who progress from PAS to actual visual loss or problems, let alone simply moving from PAS to raised pressure, is unknown and probably quite small. So laser iridotomy after the ZAP and ANALIS trials, I would suggest consider using it for all acute attacks, all fellow eyes, unless they've got cataract, in which case take out the cataract. I would propose that it's used for those with primary angle closure and pressures under 30, raised pressures under 30, unless there's cataract, in which case take out the cataract, and not for primary angle closure glaucoma unless they refuse lens extraction or are much younger patients who are pre-presbyopic with excellent vision. So emmetropes who still have some degree of accommodation that they will not want to lose after lens extraction. For the PACS eyes, well, perhaps for the very high risk, whatever you would consider constitute high risk, but perhaps for those who require regular pupil dilatation, such as for diabetics, or for patients who are unable to access medical care promptly, such as those living in the third world or traveling great distances. So my conclusions around laser peripheral iridotomy is that while acute angle closure rates are reducing, they're probably due to cataract extraction and not laser peripheral iridotomy rates. There's good epidemiology evidence to support that. That laser peripheral iridotomy is not risk-free and it does not depend where you put it. That primary angle closure suspects progressing to disease is a rare event and that visually significant events are rarer still. And even if you do an iridotomy, it does not give 100% protection anyway. So I would say that LPI should not be routinely offered as prophylaxis to individuals with iridotrabecular contact alone, and that this is now forming part of the National UK Royal College of Ophthalmology treatment guidelines, soon to be released in the new year. Moving on to alternative angle closure treatment questions. Who needs a clear lens extraction? Well, I like to think of lens management in angle closure should be the lens first and always. If they've got angle closure and they've got a cataract, get that cataract out unless they're really, really resistant to treatment. We know that pupil block is part of the disease, but it isn't the whole story. You saw this slide before with significant iridotrabecular contact there between iris, trabecular meshwork, just above the SS arrow, the scleral spur. And this is after laser iridotomy, with the lens still in the eye. But if we take the lens out, there's much greater space. Now, there was a fashion for doing iridoplasty to thin the iris, open up the angle, and make more space. But I think these days, the evidence for that, the evidence base for iridoplasty is lacking. There are some cases where it may still be viable, but in the majority, lens extraction, which is now so safe and so routine, is probably the primary treatment with a much bigger treatment effect. This is a case series of images by Pavi Agarwal of one of Winnie Nolan's cases of a young 45-year-old Caucasian with narrow angles, raised IOP, who had an iridotomy. The iris was slightly bombé, slightly forwards in the mid-dilated state at the top of the slide, but not much. It opened up very little after iridotomy as a result. The pressures were still high with pilocarpine, and she was intolerant of medication. It was only after lens extraction that the angle opened, the AC deepened, and the pressure came down. So we can see that lens extraction, in this case with iris bombé and a large lens sitting very anteriorly with pupil block, creates a very large, wide angle opening, much deepened anterior chamber. So there's a lot of early evidence for lens extraction being effective. Lots of patients with chronic primary angle closure, with comparisons with trabeculectomy in the past, all sharing significant treatment effects and large pressures. The first case series was Eric Gravey in 1988, but many others since, of which this is merely a small selection of many papers. It's also been compared in proper randomized controlled trials, comparing lens extraction alone with combined lens extraction and trabeculectomy. You would think that trabeculectomy would far outweigh phacoemulsification in terms of treatment effect, but in fact, for those that were medically controlled, lens extraction alone did extremely well, and Phacotrab had a significant number of complications, albeit with slightly fewer meds at the end. So in chronic controlled angle closure, Phaco did very well, and Phacotrab did better in these Chinese patients. In an uncontrolled, Phacotrab did do slightly better with fewer drops, but again, there were more post-operative complications. So perhaps we should be doing lens extraction alone first and reserving surgery for those where it fails. And this is precisely what the EAGLE trial, published in 2016 by Augusto Azuara Blanco, sought to look at. Again, Paul Foster and David Friedman were intimately involved in this trial, but main credit goes to Augusto for masterminding and coordinating the study. So this took high pressure eyes with either high pressure over 30 or pressure over 21 and glaucoma, and did lens extraction, clear lens extraction without cataract or laser iridotomy. They needed to be over 50, so they were now presbyopic, and they needed to have no signs of cataract. They were randomized around 400 patients for loss to follow-up. They looked at quality of life outcomes, which was comparable in the two groups, with a small difference favoring lens extraction, probably because of the refractive outcome. And excitingly, the primary clinical outcome, IOP, was, as expected, somewhat lower in the lens extraction group, but really most powerfully seen when we look at the number of medications required to keep those patients, those pressures under control. The vast majority, 60% of the lens extraction group, were controlled with no medications, whereas only 1 in 5 had that for the laser PI group. There was also much more additional surgery required in the laser PI group, with 16 lens extractions for pressure control and then 8 glaucoma surgeries, where there was only 1 trabeculectomy required in the lens extraction group. It was also in the UK service very cost effective compared to PI. We have to remember there are very specific angle closure issues concerned with cataract surgery and angle closure. The risk increases exponentially with reducing axial length. So we need to measure the axial length before committing to surgery. If the eye is very short under 20 or particularly under 19, then we need to consider checking the posterior scleral thickness and consider other modalities of treatment. The surgical risks are the standard surgical complications, but more so, and more frequently so. Iris prolapse, floppy iris, probably because of episodes of ischemia, endothelial compromise, zonial weakness, whether that's chicken or egg, whether that causes the angle closure as a result of the angle closure is hard to know. Increased rates of cystoid macular edema and hyperopic eyes, and increased rates of refractive surprise. And of course, there's a specific risk for angle closure of aqueous misdirection. So we have to be careful, but even considering this, clear lens extraction in these already very high risk eyes is certainly something that randomized controlled trial evidence would very strongly support before we do laser iridotomy. Corneal endothelial cell counts in angle closure. There is more previous damage. There is significant damage from angle closure itself, but the post-cataract extraction loss is proportionate to the shallowness of the anterior chamber. So we need to take care, but it's no reason not to do the surgery. So is it time to remove a lens? Well, consider what's already happened as in this list of potential factors to take into account. But I would say that lens extraction should be with any visually significant cataract in any angle closure. Clear or near clear lens extractions in any angle closure glaucoma, even if they've had an iridotomy in the past. I would do it certainly for primary angle closure with raised pressure, even in the absence of glaucoma, but not, very much not, as a primary intervention simply because there is iridotrabecular contact, where they probably do not need anything other than occasional checkups every few years to look for pressure. We can avoid and minimize the risks that are involved. Remember a low threshold for atropine, and be careful with the surgical management of to avoid an anterior chamber shallowing. So plan ahead and fear the worst, but hope for the best. Worth mentioning here that acute angle closure crisis and early cataract extraction that I mentioned before in the G.Gazzard trial from ophthalmology in 2012 show that outcomes were very good after early lens extraction. And this was backed up in the 2-year outcome data, and then also supported by another trial from Hong Kong that looked at the same problem. The early lens extraction had a much lower rate of requiring pressure control later on in life. One of the controversies around lens extraction is whether we should combine it with goniosinic lysis. This is certainly can demonstrate a change in the anatomy if you look with anterior segment OCT. The question is, does it matter, and is it worth the risk? The same Rahat Hussain, who conducted the lens extraction trial with me in Singapore, stayed in Singapore, went on to run a goniosinic lysis trial that showed no difference between phaco-goniosinic lysis and phaco alone. So despite what many will say on a podium, that GSL is fun to do and worth it for your patient, there is no evidence that this is better than cataract surgery alone, and in a small number of patients, it can be most definitely significantly harmful because of significant post-operative inflammation. So I do not believe that this should now be done in any but a very small, select, tiny group of patients where it's very recently formed, and probably not even that. So any significant cataract in any angle closure should probably come out. Clear lens extraction in as a primary intervention in angle closure, in high pressure primary angle closure, and not in primary angle closure suspects. Lastly, I'm just going to mention drainage surgery in angle closure. Trabeculectomy works well. We know that from Jim Kerwin's paper. We know that trabecular meshwork in acute and chronic angle closure is damaged over time, even when there is no PAS. And we know that some patients, even with lens extraction from the EAGLE trial here, will need some form of pressure controlling surgery despite lens extraction and subsequent eye drops. There are studies that as I mentioned before, that looked at this specific question: is phacotrabeculectomy, so trabeculectomy combined with cataract extraction, a good prospect? And as I mentioned before, the powerfulness of lens extraction alone means that this is probably not something that we should be doing. We should be taking the cataract out first and then dealing with the raised pressure if that was not sufficient, both in controlled and uncontrolled disease. So, finishing off, primary angle closure suspects, those with normal intraocular pressure, we should observe. Only the very highest risk requiring regular iatrogenic pupil dilatation, such as diabetics undergoing screening, should have a preventative prophylactic laser peripheral iridotomy. Those primary angle closures with lower pressures than 30, well, the evidence would still support a laser peripheral iridotomy as being very successful for the majority. Primary angle closure with high intraocular pressures is now supported to be treated by clear lens extraction with or without medications as required. And patients with primary angle closure, they should certainly have clear lens extraction as their first treatment. And those clear lens extracted primary angle closure patients who are now uncontrolled, so uncontrolled pseudophakic PACG, well, there's clearly a role for careful trabeculectomy in those, but those, I hope, for all of our sakes, will be the minority. I hope that I answered some of your questions, and I look forward to any further questions from you either now or at a later date. By all means, email me at this email here should you have any queries. All the best.